speaker will be Dr. Stephan Kemp. He'll be talking about the Gray Zone Project, which is focused on developing new tests that can provide more definite answers and hopefully reduce some of the confusion for patients and families around uncertain genetic test results, which of course hopefully could improve care and support for all those affected by LD. Thank you, Dr. Kemp.
Good morning, everybody. It's really impressive to see how far we came in the last 10 years. The progress on every different topic. It's really impressive. Yeah, I'm not a rock artist, so I don't know how this thing works. Is this better? Yeah? Oh, there we go. Now the bend. Okay, so today we're going to talk about the gray zone. And I choose this title because I think this is something that, well, many people can relate to. So my genetic test comes back, variant of uncertain significance. Now what? So these are my disclosures. This is a typical, this is a copy, anonymized copy of a letter that I think some of you in this room may have received. This is a result following a newborn screening from one of the companies that performs genetic testing. And then at the bottom, there's the clinical summary. And in this case, it's a variant of uncertain significance was identified in ABCD1. Yeah, now what? But before I go into this, I want to spend a few slides on the genome, on our DNA, and some, well, I think mind-boggling facts. So a human genome consists of 3 billion base pairs, so 3 billion building blocks. And each cell, if you roll out the DNA from each cell, it's about 2 meters of DNA. Our human body has 37 trillion cells. So if you add that up, our total length is 74 trillion meters. So to put this in perspective, if you take the moon, which is, I think, very nice here in Houston, and our planet, if we take our total length from our own DNA, from our body, we can travel to the moon and back 70 times. I think that this, I don't understand any of this. Okay, let's go on. Now, every day, our adult body produces 300 billion new cells. That means that if a cell is split in two, the daughter cell will receive an identical copy of the genome. So all those 3 billion building blocks have to be copied. And sometimes an error is made. But we have systems in our cells that correct this. But not always, not always. Sometimes an error consists. That's not such a problem. So an error is also a mutation or a variant. So when it occurs in the germline, so in the egg or in the sperm cell, it's transferred to the next generation. And then we call talking about a de novo variant. And you've heard about the de novo variant yesterday. So the human genome is estimated to accumulate about 50 de novo variants per generation. But most of these variants, they're de novo variants, they're benign or they're neutral. It's different if this variant impacts the function of a protein. But if it's not causing a disease, but it's causing a change in the function of this protein that does not cause a disease, then we're talking about evolution. So you generate a new trait. And this also is the cause for genetic diversity. And I think there's a very nice example to explain this. It's called blue eyes. No, it are the blue eyes. So geneticists trace this back to a mutation that initiated in the HERC2 gene. It occurred about 6,000 to 10,000 years ago in Northern Europe. And without going into details about the function of this HERC2 gene and this whole complex mechanism, this mutation affects melanin, it's the pigment of the eye. So if you have this variant, you don't have pigment in your eye, and then automatically your eyes are blue. So this is not a disease-causing trait. This is something that is new. And so this variant persisted through and existed throughout the world, and now worldwide 8% of people have blue eyes. This is just to illustrate when the variant is not disease causing. So when we talk about variants and mutations, there are many of them, but the basic ones are shown in this slide. And here on the top we have the DNA code, and every 3 building blocks they make a building block of a protein called an amino acid. So here we have a simple piece of DNA with 7 amino acids. So if we now change one of these nucleotides, of these building blocks, in this case if one is missing, that means that the triplets, the 3 building blocks afterwards, they are different than the original sequence, and we have a frame shift. So the protein after the variant is different. And we know that this certainly is disease causing. You can also introduce a stop, so then the protein stops. And almost in any case, this is also disease causing. This is an interesting one, or a complex one. This is called a missense variant. So now one nucleotide is changed, and you see that the lysine at the top is now methionine. And this is what we're going to talk about the rest of the presentation. The geneticists, they have developed a system to classify variants, and it ranges from benign, class 1, to class 5, pathogenic. And as I just showed you, the frame shifts and the nonsense mutations and the deletions, they are almost always pathogenic. The problem is the missense mutations. You see, this uncertain significance, you only find those in missense variants. Let's now move on to population screening. It's clear that ALD newborn screening saves lives, so it's very clear. And following many states in the United States, in 2016, Taiwan started ALD newborn screening. Pilots are ongoing in Japan, Italy, and we had a pilot in the Netherlands in 2021. In Israel, there's a pilot ongoing. I'm not so sure about the current status of it now. And I'm not talking about newborn screening, but I think this last sentence on this slide is kind of interesting, because last month the Netherlands started nationwide screening for ALD newborn screening. It was a nice article in one of the national magazines. Okay, population screening. Population screening is not the same as diagnostic testing, and it's shown on this next few slides. In diagnostic tests, a patient presents with clinical signs and symptoms at the physician. The physician looks at the symptoms, and in the case of ALD, there are indications that hint towards ALD. You take a blood sample, you send it to the lab, you do C26 lysis PC analysis or variant chain fatty acid analysis, you sequence the ABCD1 gene. If you have elevated variant chain fatty acids and there is a variant in the ALD gene and there are clinical signs and symptoms, it's ALD. That's not that difficult. In population screening, we screen the population to detect in healthy individuals potentially a disease in the preclinical stage. So we don't have clinical clues. So the entry point in this case is different. So in the case of diagnostic screening, we enter in the blue area there, and we have biomarkers that are indicative of a disease state. But in screening, we are screening, we don't know where our cutoff levels are. So how that is established in general is you take hundreds of control samples or thousands of control samples, and you analyze the biomarker, and you go to the upper limit of the reference range, indicated at the top at the green bar, and everything that's above that upper limit is screen positive. As I said here, so the cutoff level is the upper limit of controls. If you're above the cutoff, you're screen positive, and if you're screen positive, you will sequence the gene. So the problem is that there's an increased risk of identifying variants that are causing mildly elevated biomarker levels. But we do not know, so here indicated in orange, but we do not know if these variants are disease causing. Something is causing this elevated level, but is this increase enough to cause a disease? In other words, is there a benefit for the newborn to be identified? So back to the first slide. So a variant of uncertain significance is identified in the ABCD1 gene. A VAS is a variant of uncertain significance, but you can also say a VAS is a very unclear situation. Often, these variants of uncertain significance, they create a diagnostic dilemma. As I said, they're often missense mutations, so one building block in the protein is changed. They're not previously reported, otherwise we would have information. There are no clinical clues, because you screen newborn in the preclinical stage. And there's absence of family history, otherwise we also would have patients in the family and it would not be a variant of uncertain significance. So the question is this variant disease causing, or are we creating patients? And that sounds very cruel, but this is reality. So this is another interesting fact. There's a rise in VASs identified in the ABCD1 gene with the expansion of the newborn screening. So in 2023, on a yearly basis, over 3 million newborns are screened. These are the 3 of the 5 different classes of the variants that are identified, the missense variants. So the green ones are the likely benign variants, the red ones are clearly pathogenic variants, and the gray ones are VASs. And you see a nice correlation between the expansion of the newborn screening, so screening more individuals, and a rise in the number of VASs identified. So the key question is, if you find a variant of uncertain significance, is it pathogenic or is it benign? In other words, is it ALD causing or is it not ALD causing? And often this is misinterpreted. This U in VAS is often misinterpreted as we cannot predict if the child is developing adrenosinsufficiency, cerebral ALD, or myelopathy. And that is not what the U means. The U is simply, is it disease causing or not? So we have a first priority. When a VAS is identified, we need to find ways to provide an answer to these families. In LD, we are lucky, and often notice that people think, in our LD community, think that every disease has its own variant database. That is not the case. I can tell you that for cystic fibrosis there is a database, for maybe some other diseases, but for ALD there is this database that was initiated. I initiated this together with Hugo Moser in 1999 when I was at the Kennedy Krieger Institute. I kept maintaining it. In 2016 I was thinking, why am I doing this? And then I spoke to Elisa Seeger, and then the whole new world opened for me, the newborns. The first question that Elisa, I'm not sure, I don't know where you are, Elisa, you're somewhere in the room. The first question that Elisa asked me is this a university-owned database? Is this free? How can you not know this? And I said, oh yeah, no, but you come from a whole different angle into this world. I said, no, this is an open, accessible database, and so we catch all the mutations. And at that time, that was still called mutations. Now we talk about variants. And then I said, okay, I really need to continue doing this. And what's important about the variant database is that it's actively maintained and curated. So I collaborate with a lot of physicians in diagnostic labs. I also scan the literature, and for each variant there is an explanatory remark about that variant. Most diseases don't have such a database. They rely on ClinVar, the ClinVar registry for classifications. And I'm not going to bash about ClinVar because it's really, really important. But it's not actively curated. And the variants that are entered to the database, they're often entered. We don't know what the link is with patients. So, and I'll try to explain that in the next slides. So if we break down the missense variants in the ABCD1 variant database, we see that the red piece, those are the pathogenic variants, is the largest section. And currently there are over 2,571 cases with a missense variant in the ABCD1 database. So I screened ClinVar, and in ClinVar there are 1,129 missense variants reported. And you see that the gray area, the gray zone, the VUSs, is the largest portion. I took the effort of taking all those variants in ClinVar and use the information in the ABCD1 database and to combine it. And if I overlay the two databases, I can already solve a lot of those gray VUSs in ClinVar. That means, to me, that means that Invitae and other companies, I don't know why, but they are not aware of the database, or they don't scan the literature that well. I mentioned something about that yesterday, but I'm not going to present that today. I have there are. I mean, sometimes patients or families, they contact me. They say, "How can I have a VUS when you have 7 cases in your database?" I don't know. I'm sorry. I don't know, but that's something. Well, I said that I don't understand that. What I do understand is that together with Troy and with Joe Orsini and Mark Engelen, we wrote a paper, and we make an inventory on the publications from the states that publish their variants. So these numbers in blue upstairs, they're not variants, these are references, the reference numbers, I realized this morning. So in the database, so prior to newborn screening, there were about 21% of the missense variants were VUSs. In newborn screening, over 62% of the reported missense variants are VUS. So the likelihood of finding a VUS in ALD newborn screening in the current situation is 3 times higher. And this is caused. Well, I said this is not unique for ALD. In any newborn screening program, in Pompeii, in Fabry, you find an increase in the number of VUSs when screening starts. This is not unique for newborn screening. This is also, you also see this in population screening. Here the BRCA1 and BRCA2 genes. So these are the breast cancer genes. When population screening started and genetic screening started for breast cancer, there was a rise in VUSs. In fact, if you go back to ClinVar, the amount of VUSs identified by purely genetic screening rapidly outpaced the pathogenic and the benign assignments, as shown in this graph, the gray bar. And so I checked ClinVar for all the missense mutations or the missense variants that are reported for any gene. And in this year, 85% of the missense variants in ClinVar, so that's for all the diseases, are VUSs. So this, as I said, this is not unique for ALD. So the problem statement shown in this very simple pie chart, but if you think about this pie chart, this is what's behind this. Currently, over 500 individuals or families have received a report that concludes a variant of uncertain significance was identified in the ABCD1 gene. I think we have to do something with that. Because the consequences of receiving such a notification, I don't have to tell you that because I mean I didn't receive it, but it's clear it causes parental stress, anxiety. It also puts a financial burden on families because additional tests will be done or treatments will be started. So there's a rise in the cost of healthcare. Maybe unnecessary medical procedures are being performed. So then we come to medical harm. Do you need to perform tests if you don't know if the variant is disease causing? And if we continue to do this, there may be reduced trust in screening programs, not just LD screening, but population screening. Yeah, and so this causes a dilemma and psychological effects. And these are some of titles from publications in PubMed. And the interesting thing is all these publications were from the last 2 years. And they're from different areas. So this is a topic that is rapidly increasing. So our first priority is if there is a FUS, the question need to answer the question: is this ALD causing or is this a false positive? Can we tell the family, sorry, we have bad and good news. The bad news is that you received a report that you may have ALD, but the good thing is that you do not have ALD. And this is a difficult task, but I think we have to address this. And we can do this because in the ALD community we really collaborate a lot. Many of the PIs that have research groups, they at one moment they were at Kennedy Krieger with Yuka Moser. They stayed in the field. We meet here. We collaborate. We have a lot of research projects. A lot of physicians approach me, and of course we have the central database that the physicians use. So I always say, well, if you use it, you can also share. I think I'm pretty consistent in that, this message. So I like to illustrate very simply how we can tackle some of these. So this is a variant that was identified in newborn screening. And because it's newborn screening, we don't have any clinical clues. It was never identified before, so by definition, it's a class 3 or a FUS. So it's reported in the database, and it says a variant of uncertain significance was identified in newborn screening with a reference, but no, it has not been associated with disease. Then it was identified 5 times in total. So now it just changed that it was it's a FUS. It was identified 5 times in ALD newborn screening, but still we don't know if it's disease causing. What then happened is that one of my colleagues reported a patient with clinical signs and symptoms of ALD, clearly elevated C26 lysyl PC levels, and the same variant. And now we can connect the dots. And because this is one patient, we say, okay, it's likely pathogenic. So and now it says likely pathogenic identified in a single ALD case with a reference and 5 times in ALD newborn screening. So now in the future, if one of my other colleagues contacts me and says, hey, I have a clinically affected ALD patient here with this variant, and now we have 2 of those, then we can upscale to pathogenic. So the path from FUS to pathogenic is not that difficult because we also have our lysyl PC measurements. The problem is the other way around. Can you go from FUS to benign? And that is actually the gray zone project. But the gray zone project is becoming bigger and bigger, and we are all inclusive. And I don't want to restrict it to putting FUSes to benign. We can do much more. We're very lucky that this is a project that's sponsored by ALD Connect and recently by the Vinaya Tuman Foundation. And we hope that this funding continues for a long time because I showed you we have 500 FUSes. So, well, I think we need to solve as many as we can. So what happens in reality is that when newborn screening identifies a FUS, as shown here in the little boy at the bottom, what happens often is extended family screening is initiated. And often adult males with the same variant are identified. And this is very important because these adult males, they can help the newborn. I always say how the grandfather can help the grandchild in this case. Because if there's a clinical evaluation of the adult males and we collect the sample, and I prefer to have that sent to Amsterdam. And initially we started with plasma samples, but that was a logistical nightmare. And now we have transferred this to blood spots. I love blood spots, but they're very easy to make and they're very easy to ship, and it saves a lot of money. If they come in Amsterdam, we measure C26 lysyl PC in our diagnostic department. So that's not a research project, that's an official diagnostic measurement. And we have one fact in life is that all males with ALD have elevated C26 lysyl PC levels. And I want to show one almost last slide. And that is a manuscript that is being submitted last week. It's the work from Jorik Jaspers, and he will present next year, I'm sure, on this topic, because this is uber cool. And it's a massive study, and this is just one simple finding from this study. This is a collaboration. We identified this in Amsterdam, and then we said we need to validate this. And then we said, you know what, we can validate it in the same manuscript. So we contacted Wolfgang Köhler from Leipzig because he has a lot of patients. And then we said, oh, well, we also like to include more children. So we contacted Troy, and so there are many more patients in this thing, but these are the extreme ends of the phenotype. The extreme ends, the most severe form of ALD is males with and cerebral ALD and adrenal insufficiency. And on the other side of the spectrum, we have males that are over the age of 55 years. They have spinal cord involvement, but they do not have adrenal insufficiency, and they have proven by MRI no cerebral involvement. So these are the extreme ends of the clinical phenotype. And when we measure C20 lyso-PC in these two groups, and we compare that to over 1,200 controls, that because our lab in Amsterdam completely shifted to C20 lyso-PC analysis. So here in green at the bottom, we see males and females aged 0 to 80. So this is our control level. And what we see is that males that have and adrenal insufficiency and cerebral ALD, they're here shown in red. And this group of males over the age of 55 years, myelopathy, no, I said no ALD here, that's not good. No adrenal insufficiency, and no cerebral ALD. They have clearly lower C20 lyso-PC level. So in contrast to what we see in literature, there is a correlation between C20 lyso-PC levels or the biochemistry and the disease severity in ALD. I think this is really exciting for the future. But you also see that below the blue part, there's still this little white part. And I think there are quite a lot of buses will fall into that range. And that will remain challenging, but I think that if for one of us we can, and that's why the extended family screening is so important, and the adult males with the same variant, because this is a numbers game. If we have one variant and we have 10 adult males, and they're all seen by the neurologist for physical exam, and we measure the biochemistry, and these all fall, if there's very mild or very late onset or no ALD signs, we predict that these will fall really below that blue area. And I think this is the path to resolving many of these buses. So what do we expect to find, and how will we act? I think we will, in the next years, many of these variants will be reclassified as likely benign. We have to be cautious. So it's going to benign requires more proof. Also, variants will be classified to likely pathogenic or pathogenic, and that's easier. We will identify variants that are associated with late onset or mild symptoms. And in the past, these may have never ended up at the neurologist. May have been unrecognized as being associated with ALD. So this is what I said. The clinical spectrum will expand to the milder side. So the ultimate goal is that that eventually we have to set the cutoff levels for risk stratification, low risk versus high risk for development of cerebral ALD or adrenal insufficiency, which was also talked about yesterday. I think what this will also show is that the cutoff levels in screening are now too low because we find too many fusses. And this is a project that Joe Orsini from the newborn screening lab in New York State started years ago. And to be honest, 4 years ago, I had no idea what he was talking about. And I said, how can it be? Every variant in ABCD1 is causing disease. Okay, I learned the hard way. This is not the case. And this is the harmonization project that is also run by the ALD Alliance, where we have every year we have meetings with the states, and this is really, really important because that is the place where we connect with the states and the screening labs, and we can talk about this. And as an example, when the Netherlands started screening last month nationwide, we already raised the second, well, it's our tier 3 because we have the X counter, but it's the tier 2 in the United States. We raised it from 150 nanomole per liter to 200 because all the screen positives that we had under the 200, they were all did not have ABCD1 variants. So we already used the information from the pilot to set the level in tier 3 a little higher to prevent the identification of buses. So this is the qualifications for the gray zone, but I said, well, we accept more if there's a reason to do that. So if your baby was diagnosed with ALD via newborn screening, if the report comes back variant of uncertain significance, and if everyone in your family who has ABCD1 mutation is asymptomatic. So this is the extended family screening. Yeah, then you can join the gray zone. If there's no extended family screening and there's only one individual, one newborn that receives a report, of course, that also qualifies. Yeah, and then my acknowledgement. Like I said last year, I cannot thank one person. This is truly a worldwide community project. And of course, special thanks to the ALD Alliance, ALD Connect, and the Toolman Foundation for funding this research. Thank you.
Thanks so much, Dr. Kemp. And this is really critical work, especially as the newborn screening is really expanding globally. So I think in the interest of time, we can take 1 or 2 questions. Yep.
Hi, Stephan. Phenomenal and so needed. But I'm also a little troubled by some of the conceptualizing here. I think if you start defining severity of ALD as having either cerebral ALD or adrenal insufficiency alone, I think there would be plenty of evidence in this room that having a severe myelopathy is just as severe, if not more severe. And you have to be very careful about how you are attempting to classify. And I think this comes back to a very basic question, which is, I think there is a false reassurance in relying on very long chain fatty acids or LPC to predict the course of the disease. And we've known this for a long time. I know we want to give some guidance, but I think this is going a little in the direction of false reassurance. And just to also point out that there have been, over the years, publications on discordant monozygotic twins, right? And we should not forget all that legacy of science in the past. And so I'm being a little facetious here, but with the highest respect and regard for what you're doing.
I fully agree with you, Florian. This was a huge simplification. The last slide was a huge simplification of all the data that goes in that manuscript. So it's there are many more there's much more data, but this is just a finding that we did, and of course we will expand the numbers. So and to tell you, yes, I agree. In the literature, there was no correlation between variant chain fatty acids and disease severity, but it has largely to do with the fact that those samples often came from individuals years before, and the clinical information was not updated. Because if we now look at variant chain fatty acids, plasma, total variant chain fatty acids, in this huge cohort, there is also a correlation, which I didn't want to believe. So in the beginning, it was because it was not there. But the groups that were analyzed 20 years ago, I mean, with all respect, there was limited information on the phenotyping, and it was not always up to date. But actually, this goes beyond the gray zone, because the problem is, of course, I mean, if the C20 lyso-PC is in the disease range, we are done. The gray zone is not to predict. The gray zone is to give answer to, is this a likely pathogenic or benign? So if we reanalyze the C20 lyso-PC and it's below the blue one, and this blue group keeps expanding, and they're all sitting down there, and the measurements are even below that, then it is very unlikely that this will be a cerebral ALD causing thing. And of course, you're right. I mean, there are always exceptions. But if we live by the exceptions, then we have a problem with all these 500 reports. So, I say, yes, but we have to do something with these 500 families. And I think what is worse, 500 families having no idea what to do. But this, with all the anxiety, the stress, the financial burdens, so we have to address this. And of course, yeah, I mean, your point is really, really well taken. And I think we are in the lucky position that we will be able to address this even further because we collaborate. Other diseases, they would have a much harder job to do that. And I think the C20 lyso-PC is just a very strong biomarker that we have. And it's stronger than we realized. And this research is pointing to that direction. And we can just, it's a whole different project. It's not part of the gray zone, but it really comes together very nicely. Yeah.
Hi, Stephan. So I had a follow-up question about that. The samples that you analyzed for the C26 lyso-PC, I assume the timing of the sample was at the time when the patient was presenting with cerebral ALD, right? So, so I guess if we think about it from a old-fashioned storage perspective, you would anticipate that over time you will accumulate more and more C26 in your membranes. So do you think that?
Membrane, yeah.
I guess this is plasma or this is RBCs?
This is
plasma. So it could be lyso-PC coming from anywhere, right? So I guess what would be really interesting is to see if you have samples of them before they had cerebral ALD and see if that C26 elevation is something that's there or if it's something that happens as...
We have.
Okay.
And this was a huge simplification, but we have samples of 3 boys before, or 3 males before developing cerebral ALD, and they were in the same range.
They were already elevated.
Yeah, they were already elevated. In the same range. They were already in the cerebral ALD range.
Before they had cerebral ALD.
Yeah. So, and so now we go into the potential predictive prognostic, and now I don't want to go there. But this was just an observation, so we need to expand this. But
okay.
Yeah.
Right, I'm falling off my chair. Okay.
Yeah. Another one. We debunked a paper that we published ourselves, which a lot of you didn't believe. Because we wrote a paper, a follow-up on bone marrow transplant, and we published that the bone marrow transplant did not lower the C26. Thanks to Troy, we have samples from 10 kids. Yeah, but in the study, I think 10. Baseline, 6, 12, and 24 months post-transplant. They don't normalize, but they all go down. So our own publication from 10 years ago was incorrect. But we measured, the C20 lyso-PC goes down. It responds to therapy. So this also has implications for clinical trials that are focused on the biochemistry. But this is all not gray zone. So are there gray zone questions? If not?
And Stephan, we have one more question.
I think this should be an easy one. But I'm a Houston mom with 2 ALD boys, both BUS, and I've noticed that the very long chain fatty acids are reported with a variety of units depending on what lab it's tested in. So we got our results from KKI, which is in I think it's micrograms per milliliter. So I was looking at your chart. Is there a reliable conversion we can use for
No.
results between labs?
No, these measurements are lab and machine specific. There's another important thing that I didn't show is repeat samples, you need to take into account the age of the newborn, because after birth the levels drop, because the lyso-PC is part of the membrane of the erythrocyte, the red blood cell, and at birth the red blood cell count, hematocrit, is higher, and in the first weeks, a month after life, it drops. And what you see, we did a follow-up on one of the kids that we picked up in the pilot, and we had the samples of 3 and 6 months, and we do see a decline. So the cutoff for newborns is higher than the cutoff for, as I call them now, non-newborns. So and so I have requests for gray zone measurements, and for now we say, well, we have to wait until the child is older than 6 months, because then we know they are in the other cutoff range, and then we can compare the measurements with the over 1,200 controls that we did and the confirmed ALD cases. And that's an important piece of information for rescreening. You have to take into account the age of the newborn, because the levels drop.
Thank you so much. Okay, so next we have a panel. I'm actually excited to introduce 2 of my colleagues from Kennedy Krieger Institute in Baltimore, Maryland, Dr. Christina Sadowski and Jennifer Keller, who are going to talk about an important and probably not discussed enough topic, ALD below the belt. Thank you.
Hello, so a change of pace. Just a moment, I want to announce in the room, we know it's cold. We've asked them to fix it. It is warming up. This is not just us trying to get you outside to drink coffee and be hyper-caffeinated to stay warm. Although that works sometimes. But I do want everyone to know that we're addressing the situation, and so hopefully we'll get some relief. For those of you at home, I hope you are toasty and temperate and in a wonderful, comfortable place. So we're changing the pace a little away from gray zone and to a topic that comes up in patient discussions all the time. We talk about balance, we talk about gait, we talk about spasticity and pain, and then there are the questions that people are a little more hesitant to discuss. And so for years, I've been saying we should have a discussion about ALD below the belt, not just your feet and your legs, but let's talk about bowel, bladder, and sexual dysfunction. They are issues that patients report amongst and between ourselves and our physicians, but can be challenging to find expertise. It can be challenging to find guidance, and people are often too hesitant to bring it up even with their own providers. So I thought, let's just have a nice Saturday morning chat about those 3 hot button topics. So I'm going to allow my panelists to introduce themselves. We have Jennifer Keller and Dr. Christina Sadowski. If you want to just give your backgrounds, and then we're going to chat.
Hi, I'm Jen. I'm a physical therapist and an assistant professor at Kennedy Krieger, and I started with research in AMN with Dr. Mosier with the Lorenzo's oil study, so it's been a while. And usually I talk with you about balance and gait, but I've been invited to expand a little bit of my knowledge to you today on this topic. So thank you for having me.
Sorry, I didn't say hello to anybody today, so I'm saying hello to everybody else here. Thank you for having me. I'm Christina Sadowski. I'm an associate professor of physical medicine and rehabilitation at Kennedy Krieger and Johns Hopkins. Why do I get to share this time with you is because I, in my capacity as a spinal cord injury medicine specialist, I am very familiar with neurogenic bladders, and I perform neurodynamic studies at Kennedy Krieger, including on individuals that come and seek expertise in the ALD clinic. So that's my claim to fame.
Excellent. Well, thank you both for being here. And I'm going to ask just for everyone in the room as well as people on Zoom, we will be taking questions, but instead of us putting together a presentation and trying to explain lived experience to people who live it, we thought this would be a wonderful opportunity to get the discussion started, and hopefully I'm asking folks to be brave and to ask your question. As always, you have an opportunity to put it in through Zoom. You can pass a note. We can go full 7th grade on this, but really, we are all together, and I just would love people to really get the clarity you need. So I'm so glad that you both agreed to do this and talk. I know certainly I'm fortunate enough to be part of the symptomatic women's group that meets on Mondays once a month, and it comes up with great frequency, no pun intended, bowel hesitation, bladder hesitation, bladder frequency, leakage, a whole bunch of other topics around neurogenic bladder. And I'm wondering if either of you feel comfortable to describe maybe why or how, what is the fabled neurogenic bladder, and if there's anything that either of you would suggest that people do to accommodate that, or tips and tricks or treatments to get around that.
Okay, I'll start with the reason. So ALD is a central and peripheral nervous system disorder. So it affects the control of the bowel and bladder through affecting the autonomic nervous system, which is the nervous system that controls everything whenever we're not thinking about controlling breathing, heartbeat, blood pressure, bowel, bladder, the spontaneous evacuation. So we have all kind of changes in individuals with symptomatic individuals with ALD. They can be what we call overactive detrusors, so increased urinary frequency, urge incontinence, needing to go very frequently to the bathroom, and probably having the cold temperature here, plus the hot coffee, the caffeine, probably that triggered a lot of bathroom visits today. So that's one type of bladder problem. And I have to say, bowel and bladder are innervated by the same system, so they kind of